Welcome to JAMA Plus AI Conversations. I'm Dr. Roy Perlis, Editor-in-Chief of JAMA Plus AI and today's host. I want to welcome our guest, Dr. Michael Pencina, a professor of biostatistics and bioinformatics at the Duke University School of Medicine and Duke Health's Chief Data Scientist. Dr. Pencina also co-founded the National Coalition for Health AI, or CHAI, but we'll get to that in a bit. Michael, thanks for joining us. In your September 10th article in JAMA, you argue for a federated registration system for AI in health. For the non-technical folks who are listening, can you say a little bit about what that might look like?
Right. Well, first of all, thank you for having me here. Delighted to be talking to you about these topics that I'm very passionate about, given all the promise that AI brings and also the pitfalls of the technology. So I strongly believe that every organization needs to know what AI solutions they have implemented. And in particular, given my role in Duke Health, health systems should know, keep track, or keep an inventory of AI algorithms or other AI solutions they are running in clinical care and clinical operations, right? So the idea is, imagine a portal where you record all the AI that you're running and all the information related to it. And then the federated registry, say Duke does it, but another health system does it and another health system, right? So it becomes national. And then that opens really interesting opportunities for collaboration, information sharing, enhancing the ecosystem, as well as transparency for patients, our ultimate stakeholders.
So I want to talk more about the registry itself, but before we get there, how did you get here? How did you start thinking along the lines of a registry in the first place?
So in late 2020, we put together our algorithmic governance for Duke Health System. We called it ABCDS, Algorithm-Based Clinical Decision Support. And that originated from a real need. There were a lot of developers, internal, right, our bright faculty, as well as external, startups connected to Duke, not connected, larger companies, banging at the door of our health system and saying, oh, please use this algorithm or buy this algorithm. It's going to do miracles for your patients, save you tons of cost and money, right? And it's just a great thing. And we were not well equipped to really differentiate between those that do bring value and those that do not. So we established our governance process, modeled it on what FDA does with medical devices. The reality is the pace of the AI revolution is much faster than our neatly designed process. There is so much AI, right, with the GPT revolution and everything that we're seeing. The process that we have that's really good and solid with principles, it's just too much for our organization to evaluate every AI technology that we think we might want to be employing. So we said, well, okay, we need to do something different. We need to decide which tools are higher risk. And if something is touching the patient, predicting risk of a serious condition, whether it's sepsis or hospital admission, heart failure deterioration, right, we might apply more scrutiny to a tool like that versus something that is maybe creating a note for a clinician to review, right, which is inherently lower risk. But whatever it is, we need to know that we're using it, right? We cannot make a decision how much scrutiny to apply if we don't know that we have it, right? As we wrote in the paper, you cannot manage what you don't know you have. So the registry became a necessity to respond to the volume of AI that's coming upon us.
So I guess one of the things that surprises me, but probably shouldn't surprise me, is the extent to which health systems wouldn't know what's going on in their own hospitals and networks.
Well, they do not. It took us 3 years since establishing our ABCDS governance to have a fairly good overview of everything that we have, but it's still not perfect, right? We had an instance of a vendor with a diagnostic device that implemented AI, and we didn't know about it. The AI malfunctioned, and we had to recall hundreds of patients to get retested, right? That was not registered. It wasn't one of these algorithms that was internally developed, and it was kind of a little bit in no man's land, right? So in response to that, we're actually creating a policy that will mandate registration of certain tools within our health system, because we really need to know to avoid issues like that, right? And you multiply it by 10 or 100 because AI is getting everywhere, and then the problems will only grow. So that's why the inventory is so critical.
I'm intrigued by what you said about federating so that other health systems can share the burden, that it's too much for any one system to take on all of this evaluation. What's the response been when you talk to people at other places about participating in something like this?
It's been extremely positive. I will say the desire for collaboration among health systems in this day and age of AI is something that I have never seen in my career, right? Everybody is realizing that we want to serve our patients, and we have a tremendous opportunity with the technology. We're working in a difficult environment, right? After the pandemic, clinician burden is a huge issue. Costs have increased, revenue did not match, right? Margins are squeezed. So all health systems are struggling. So everybody is realizing that AI is an opportunity to make things better. But working individually, we as health systems are at a clear disadvantage, right? I was at the Coalition of Health AI meeting at Health conference last week, and somebody made the point that if you take the cost of single evaluations of a given tool by every health system, right? So we want to deploy this algorithm, and Duke evaluates it, and another health system evaluates it, right? And everybody does it kind of in silo. If you add all the costs of evaluations, probably more expensive than the original cost of development of the AI technology, right? That's not sustainable, right? We cannot operate like that. So sharing information becomes critical. Also, now we're talking pre-deployment. What is probably more important is the post-deployment experience, right? How do we find out? Duke, with our 3 hospitals, right? We're kind of medium-sized health system. It might be that the larger health system finds out a malfunction of an AI tool that needs to be corrected. We'd like to know that. And then on the other hand, we're talking with health systems in under-resourced settings that they don't have the ability or the resources to perform these evaluations and monitoring. And they're saying, we're going to be left behind at the mercy of algorithm developers. That's not fair, right? That's the other dimension of health equity, which is not on the patient level, it's on the health system level, right? Is the care that you get dependent on where you live or what health system you're interacting with, right? So the hope and idea here is that this federated registration system will enable sharing so everybody has access to that information.
I'm glad you raised the analogy of post-marketing surveillance, because one of the things as I was reading your article that I was thinking about is, even if institutions are similar in their infrastructure, they're so different in the patient populations that they serve. And your Epic is different from our Epic, is different from someone else's Epic. And when you talk about federating, how worried are you that these places will be different enough that it'll be hard to reconcile across institutions that can otherwise be so distinct?
I'm very worried, right? I'm looking at what happened with the implementation of the electronic health records and the fractured environment that we've created. So that's the reason I co founded the Coalition for Health AI. I like to say what we need is national standards, but local governance, right? I fully and deeply respect the knowledge base and the ability of health systems to make best decisions for their patients where they are, right? So I'm against a national governance of all AI. That's not workable, right? You need to push it as close to the patient as you can. At the same time, standards in which the information is recorded to have any sharing whatsoever has to be national, right? So we're working with the Coalition for Health AI on standardizing what we call model cards, right? Think about those as entries that would be filled out to create that inventory, right? So we're bringing all the members, thousands of members of Coalition for Health AI to give feedback and say, okay, that makes sense to ask the question about this algorithm in this way. Because if we do it at Duke one way, right, another health system does it another way, so on and so forth, as you say, the information will be unreconcilable. So we've wasted the opportunity. If we ask the question the same, the information is standardized, that enables sharing.
But I still think there's a fair amount of investment required for any given institution to implement this kind of thing. And I guess if I'm the CEO of a health system and we're losing money and we're dealing with this problem and that problem, isn't it easy to say, well, this is great. I'm going to wait for you guys to figure it out. And then I'm just going to use your scorecard. And thanks so much for building this for me, but I don't want to be part of this. What do you say to them?
Well, so I really hope that we can move beyond treating AI governance as a luxury, right? For me, AI governance is table stakes. And I think the question of the ROI, return on investment for AI, is a good one. I will say, I'm going to make a prediction that in the next 2-3 years, we're going to move from the hype of AI to the value of AI question, because there is so much, right? We cannot implement everything. So health systems will have to become more choosing, and that will be dependent on value. But if you see value in implementing AI, you should see value in having governance. And I will say the registry, the inventory is the most basic level of governance, right? We're not talking about running randomized clinical trials within health systems for every AI technology, even though I think we need to put a lot of resources as a nation in enabling that, because ultimately we need it, right? We were doing it for drugs and devices, and for high risk AI, that's absolutely what is necessary. The inventory is a very low touch kind of starting point to governance. And I'm working with a couple of technology providers to create a blueprint, right? Create an interface that it will be easy to implement and relatively inexpensive to make it happen. Because again, following the national standards model cards, because if everybody has to build it on their own, right, the cost is going to skyrocket. So I think I totally understand your question, and my response is 2 layers, right? If we believe there is value of implementing AI, there needs to be value in having the inventory, and we have to make sure that the cost of maintaining the inventory, cost of governance, is contained.
But if I understand you correctly, this is not a replacement for doing randomized trials or other sorts of sort of post-marketing studies. This is kind of the least common denominator. We should, at a minimum, we do this, and then ideally we'll need to go beyond that.
Exactly. Yeah. No, this is the starting point. And the nice thing about it is you can add, right? If you have a randomized trial, that's fantastic, because the information you're putting in the registry is of higher quality, right? The success of this entire registry inventory will depend on the value and quality of the metadata, right? The information that's integrated. So randomized trials are great. There are other things that you can build on it, right? So we're thinking about the safety surveillance mechanism to capture serious or other adverse events related to AI, which is not easy, right? Because how do you know that? What's the attribution mechanism? I spend a fair amount of work in medical devices, and we talk about unexpected adverse device experiences, right? So I like to talk about the unexpected adverse AI experiences that we need to be capturing. And when you have a registry, you know what you're running, you can start talking about the attribution of these adverse experiences to the AI operating in the workflow.
I want to switch gears a little bit. I can imagine this kind of a scorecard or this kind of a framework being very valuable to a CIO or CTO and to policymakers. Do you see a role or a use for this for individual docs? say, in a given health system?
I think so. I think it's for individual doctors. I also hoping there would be a version for patients, right? So if I'm a practicing clinician, doctor or nurse, having that inventory, having a view of what my health system is running gives me the ability to kind of know what to expect. I might want to learn more, read about this algorithm, know what is behind it. Am I going to trust it? Right? I've heard a very scary story at the chai meeting at the health conference. One of the nurses was saying that she works in an environment that she feels coerced to use what the AI technology is telling her against her clinical judgment. We don't want that, right? This is AI going way too far. And I think having the registry enables practicing clinicians to be prepared, right? And have the information. And these are clinical decision support tools, right? It's a support tool, not a replacement. So knowing more about them gives them the ability to make a more informed decision how and if they want to use it. Then what I would like to see is every health system that has this inventory has a version, a website that's patient facing and saying, okay, Duke Health is using AI technologies in this way, right? Being very transparent so patients can see it.
So you anticipated my next question, which is how do you make this kind of material more interpretable, either to the average clinician or an individual patient who may not be an expert in this? Because when I look at the more technical sites at the description of these models, I'm in the field and it's hard for me to know what they're doing. So how do you do that? How do you actually accomplish something that is clinician or patient facing?
That is a really good question, right? What comes to me as a patient, and I'm thinking about informed consent forms, right? And reading it. And the purpose of it was legal protection, not information, right? So we need to avoid that. I believe there are multiple layers in which that information is gathered and recorded, and we talk about it in the paper a little bit. You have categories of information that only the developer knows. For example, what data they train their algorithm, what version of AI or what type are they using, right? I, as a health system, will not know it. So that's the kind of model perspective or algorithm perspective or model card. So they put that information. So that's kind of one dimension. The second dimension is the information that the health system knows. So how are we applying this AI technology, right? We have another article in JAMA that appeared online where we talk about indication, right? For clinician, it's really not the algorithm, it's the use case or in the clinical indication for that algorithm. So as a health system, I will really be recording the indications, not the algorithms themselves, right? I can have different vendors, different algorithms working for a given use case, like say ambient voice recognition, right? I have a choice of vendors I can put in. And then the third is the information summary that's meaningful for either the clinician or the patient, right? So it's an extract maybe from the deeper level information provided by the vendor combined with what the health system has recorded, having an extract that's written in a language that's broadly understandable, right? And working with the Coalition for Health AI on the model card specifically, we're working really, really hard to make sure that it's simple. The challenge is what's the balance of simplicity versus completeness. But I think it's totally possible to have different views for different audiences.
I really appreciate your transparency point. And one of the things that it makes me think about is the fact that we know trust in healthcare and trust in medicine in general was perhaps declining before the pandemic, certainly declined at least during the pandemic. Do you think that these kinds of registries will be helpful in terms of trust, or will it scare people away when they see, wow, I can't believe all of this is so automated, or I can't believe that there's a computer that's helping to decide X about my care?
Well, so I think it's a must. I think to really build trust and continue the special relationship that clinicians have with their patients, it's information that should not be withheld. And at first, there might be worry and concern. I hope that being upfront, right, and being transparent will prevail in the public perception so that the health systems or organizations, right, this is not just health systems, but imagine payers being transparent on how they are using AI in their workflows, right? That's all that information that we would like to have. And I think those that are more transparent will be ultimately more trusted. That's definitely my hope.
And speaking of trust, do you think that this happens organically? You mentioned the coalition and the work that you're doing. Can this kind of a registry and the things around it grow up kind of from the grassroots, from the organizations that are already part of CHAI? Or do you need some federal involvement or some sort of larger scale involvement of government to make this happen?
I think it's yes and approach. So I'm obviously very actively talking about it and promoting the idea that an inventory is the way to go for every organization. And I'm getting very positive feedback, right, from health systems in particular. And they're saying, yes, we agree with this approach. So that is very positive. I will say the Office of the National Coordinator HT1 rule was very helpful with the 31 criteria, which kind of was a starting point of disclosure, right? They are making EHR vendors responsible for transparency. I will say in my conversations with lawmakers, I argue that transparency, as we said before, as the kind of least common denominator, should be universal. I think more could be done to incentivize developers of AI algorithms to be more transparent, right? Fill out the model cards and not try to hide behind IP protection and things like that, because there is a way to disclose information and still protect all of your IP, because we're not asking about bitter details of these algorithms. We're asking about basic information, right? What technology is behind it, what data it was developed to be able to make a more meaningful decision as a health system, whether we trust this tool to be applied to our patients or how much evaluation we need to perform before it can happen.
So let's switch gears a little bit. I want to give you a chance to talk a little more about the coalition and what you're trying to accomplish. So, can you sort of take me back? Like, what was the need for starting CHAI? How did you decide we need something like this in the world?
Right. So, talking to peer institutions, what we realized is we're trying to solve the same problems internally in silo. And then it dawned on us, oh, what is happening will very quickly lead to what happened with the EHR and the fractured environment. And we said, we're trying to solve these problems. It would be so much better for us to work on it together and standardize to the extent possible, right? The notion of national standards for AI is very dear to me and all the members of CHAI. Let's not do it in silos ourselves. Let's join forces and develop things in a way that scales, right? And then bring it back. And what we did, we took some of our best practices with our algorithmic governance at Duke. We gave it to CHAI and said, this is a starting point, right? Take as much of it as you want, but we wanted the national input so that we will take it back. And what we're running at Duke and ABCDS, now it's going to follow the national standard rather than our local standard.
It's impressive the number of different organizations that are at the table together. I do wonder, how do you make sure that there are patients at the table and clinician perspectives at the table? You know, you have big groups, right? You have some of the big AI vendors, you have some of the big healthcare institutions, but I mean, how do you represent everyone at that table?
Right. So it's the diversity of CHAI, right? And what's important is everybody's voice counts as one. So we have the larger organizations. We actually, as CHAI, have many more small organizations, right? Startups and vendors. We have a lot of health systems, including statewide health systems representing the clinician voice. And we have several patient organizations, right? So everybody is contributing very actively to it, and we're very careful and intentional to make sure that one voice does not monopolize it. And I will say the conversations have been very rich, right? Whenever I attend the CHAI meetings, I'm like, wow, this is a really good discussion. I'm learning so much. I'm so excited to be a part of this effort.
I'm Dr. Roy Perlis, and I've been speaking with Dr. Michael Pencina about his article advocating for a federated registration system for AI in health. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.